Good morning, everyone. We're just going to wait 1 minute as folks are starting to join today's webinar. All right. Good morning, everyone. Thank you for joining today's webinar. Our webinar today is Area Agencies on Aging, the Cornerstone of a Future-Ready Network. As we're waiting for folks to jump in, let's go to the next slide. We'll go over some initial announcements. Closed captioning and ASL interpreting services are available. You can access this by clicking the icons at the bottom of your Zoom toolbar. All participants are muted during presentations. This webinar is being recorded, and the presentation and recording will be archived. You can visit CDA's YouTube channel to view, and it will also be posted on CDA's website as well. Again, a reminder, all participants are muted. We don't have a Q&A session during this webinar. It's mainly information only. However, we do have an email address that we'll present at the end. If there are any clarifying questions, feel free to send it to that email address. All right, let's go ahead and get started. Next slide, please. We've got a packed agenda. We'll start off with our director, Susan DeMorris. We'll hear about data and demographics. We'll move on to core programs and then learn about the intrastate funding formula and then hear next steps. So let's go ahead and get started. I will turn it over to our director, Susan DeMorris.
Good morning, everyone. And Connie, thank you for the transition. And thank you all for joining us today. May, as you know by now, on the 29th is Older Californians Month. And this year's theme is Powered by Connection. Today, we want to connect with you on the topic of area agencies on aging, the backbone of California's aging network. AAAs have been the primary source of services and supports for older Californians and their families for 50 years. Area agencies on aging, or AAAs as they're referred to, have been in focus this year. Whether we're talking about the Master Plan for Aging, new federal rules from the Administration on Community Living, the California 2030 report and recommendations, California Health and Human Services Agency program priorities, proposed legislation, or the budget process, there's great interest in the role of AAAs and how they meet the current and future needs of older adults, people with disabilities, and family caregivers in their communities. The purpose of today's webinar is to level set on a few topics that are familiar to many of you, but may be new information to other partners and stakeholders. This is a bit of a 101 or a tutorial on the key underpinnings of today's AAAs. Our hope this morning is to build common understanding of where we are currently today. This foundation serves as a springboard for future planning that started in 2019 with Governor Newsom's Master Plan for Aging and continued with robust stakeholder engagement throughout 2023 in CDA's California 2030 initiative. I want to extend special thanks to our CDA team for leading today's discussion, Ross, Denise, Nicole, and Mark, and Connie and her communications team. I want to acknowledge our thought partners in this work, Collaborative Consulting, and to our AAA partners who are joining today, as well as our stakeholders, C4A, the California Commission on Aging, CSAC, CWDA, CFILC, and so many others. Together, we're building an aging network for 1 in 4 Californians who will be age 60 or older by 2030. To start us off, we'll hear first from Ross Lalian, CDA's research chief. Ross, I turn it over to you now.
Thank you, Susan. Hi, everyone. Thanks for joining this morning. So I'm going to kick things off with data and demographics. Should be a good way to kind of set the stage for the rest of the topics today. Next slide, please. The overarching purpose of my presentation is to establish CDA as a data resource for you. We're here to help you as necessary, so I'll describe relevant data assets. I'll share a few examples of how we may utilize these data. Then I encourage you to reach out to CDA and to me to discuss how we can help you use data to better understand the populations you serve, or other ways we can help you with the research and also with data. Next slide, please. So I want to begin by providing a high-level overview of data sources that we use on a frequent basis. It's important to me that you all know that we use reputable sources that are high quality and have a history of proven data quality. Also, most of the sources that we use are actually administrative data sources. Administrative data are those data collected through the administration of program and or operations. Generally, these are data that are very high quality and also rare. And generally, these data are collected and maintained by government entities. So we usually don't have to worry about sample size, weighting data, and things of that nature with administrative data, because it's usually not a voluntary data collection effort like a survey is. So these data are effective in terms of program evaluation, understanding demographics, etc. We use administrative data frequently. We also do use some survey data because there's always going to be data gaps, right? So on this slide, you see a variety of data sources, not a comprehensive list. The administrative data includes federal data sources like the Social Security Administration, and state data you see listed from the Department of Finance or from our colleagues with the Department of Public Health, etc. Examples of survey data includes the census, which is kind of the gold standard of surveys, and something that we're all familiar with and is obviously widely used. We also use the California Health Interview Survey out of UCLA, another high quality, reputable survey that's been around for years and is widely used and also respected. So survey data that CDA uses is always going to be from a trusted source. Next slide, please. I want to transition to examples of how we may use data to better understand those that we serve. This chart displays state population data, both historic and projection data from the Department of Finance. And what this shows is that overall state population will essentially kind of taper off. However, the older adult population will grow and make up a larger share of the state population. In 1980, the 60-plus population was only about 14% of the state population. This will increase to nearly a third of the population in 2060. Something else that jumps out to me is that green line, and that is the 80-plus population, who are projected to make up about 10% of the state's population in 2060. In 1980, the 80-plus population was only about 500,000, which was only about 2% of the state population. So massive change there. Exciting to think about longevity and the opportunities that opens up for us. But with the lower proportion of that 18 to 59 population, there's also some challenges, right? Thinking about how does this population shift impact the actual economy and the actual workforce. The workforce is already a challenge in terms of shortages in so many critical sectors. But with fewer working age adults, it may be even more of a challenge. Thinking about the caregiving workforce in particular, as we're projected to have a significant rise in that 80-plus population. Next slide, please. And projected older adult population growth is actually not uniform. And this map kind of shows that there's areas throughout the state where there is going to be significant growth. Sacramento, the San Joaquin Valley, Southern California. But there's also areas that are projected to actually see a decrease in the older adult population when you compare 2020 to 2060. That's Northern California and the Sierra region. Within those communities, older adults will still comprise a larger share of the overall population, but the population across all ages is expected to decrease. So the opportunities and challenges may differ by region, and that's why it's important to be able to take that more granular look at these data. Next slide, please. And a big piece of this population shift is changes in demographics, things like race, ethnicity, and also languages spoken. This chart displays the racial and ethnic shifts at the state level. The table below is broken out by region. And what this shows is that Hispanic older adults in California will comprise a much larger share of the older adult population. In 2020, they comprise about a quarter of the older adult population. By 2060, this will increase to about 40%. The Asian, Black, Pacific Islander, Alaska Native, and multiracial groups will stay relatively similar in terms of their share of the older adults in 2060. However, white older adults will make up a larger share of the state population. In 2020, they comprise about half of the older adult state population. This will decrease to about 35%, but 35% potentially. And so we're able to break these data out at the regional level, which may be helpful to you. I want to emphasize the importance of that. In terms of healthcare services, culturally competent care and culture concordant care will be even more important. And this goes hand in hand with future linguistic needs, and I think that's a good segue to the next slide. This is a different way to display data here. So I want to make sure to show different examples of how we can display data so you can get a sense of what's possible and what also resonates with you. So the gray on this chart represents the share of older adults by county that speak only English. The blues represent folks that speak a language other than English, but speak English very well or well. The pink is older adults that speak a language other than English and speak English not well. And the red are folks that don't speak English at all. So essentially the counties on the left-hand side of this chart may face challenges when it comes to culturally concordant care and some of those language services. And by county, we see that the needs vary quite dramatically. And that's why I like this visual. There's a lot of data on here, but we can still have that quick takeaway. So it's important to us, again, to be able to provide you with that regional data. There's another important point here that is thinking about 2 slides ago, that map which displays regional variation in terms of that older adult growth. A lot of the counties on the left-hand side of this chart will experience that significant growth. So these data points are actually connected, and it's powerful when we're able to take a more holistic look at these issues because they are multifaceted. Next slide, please. So I'm going to switch topics and share data and a couple of visuals around older adult homelessness. Typically, we define older adults as 60 and over, but for homelessness data, we generally define it as 55 and over. That's due to life expectancy and other challenges faced by unhoused individuals. So individuals over the age of 55 are the fastest growing segment of the unhoused in California. The chart displayed here shows a steep increase, right? And so the rate of older adults homelessness in the state is actually nearly doubled from 2017 to 2022. If trends remain the same, the rate will unfortunately continue to increase at a rapid rate. The most current data from the Homeless Data Integration System shows that the rate of older adult homelessness is nearly 60 per 10,000 adults aged 55 and older. And the projections show that this rate may increase to nearly 108 per 10,000 older adults by 2030 if the status quo remains. Next slide, please. This map displays the rate of older adult homelessness by county. The darker blue on this map represents higher rates, right? So what this shows is that homelessness is not only an urban issue. Our colleagues that would actually work in rural communities and others on this call, you all are probably aware that homelessness crisis impacts rural communities, but maybe not everyone is aware of how significant it is. And most of the discourse around the unhoused focuses on those urban communities, but it truly is a statewide issue. Of course, in urban communities, LA, the Bay Area, et cetera, the number of unhoused individuals is greater. However, looking at this as a rate unlocks other insights. And according to data from the homelessness data integration system, Humboldt County has the highest rate of older adult homelessness. So these types of visuals are critical as we inform our stakeholders about how widespread this issue is in California. Next slide, please. So I'm going to switch gears a bit and describe an index we created by using many of these data sources. So we call this the Greatest Social and Economic Need Index. And essentially, we wanted a data-driven method to better understand need throughout the state by county. And after conducting a scan, we realized that there's a lot of helpful and useful indices out there, but there isn't one that's customized to the needs of older adults and looks at the wide range of issues. And that's the genesis around the creation of this index. We wanted to get really granular and understand what the more specific needs of counties are. So we integrated many data sets to understand those needs, and we think this can be really helpful resource to everyone, to the AAAs in particular. Next slide, please. There's a lot of text on this slide, maybe hard to read. I apologize, but I want to display the 18 different data sources that make up this index. We actually created a method to integrate these data and create an overall index score. The overall score is needed at a much higher level, although the powerful piece of this index is that we're able to look under the hood, so to speak, and understand what factors are driving the score. I'm not going to get into details of methodology today due to time constraints, but if anyone's interested, please feel free to actually reach out to me. So this index includes demographic factors such as the proportion of the older adult population that doesn't speak English, the racial and ethnic composition as well. We looked at geographic need by factors such as health professional shortage areas, and those are communities that lack primary care providers of health, prescribing clinicians. We looked at Alzheimer's rate and housing cost burden and population growth, number of veterans by county, even environmental factors that are calculated by the National Risk Index. So I would characterize this as a comprehensive index in terms of different needs of older adults. Next slide, please. This is an example of how we can view the Greatest Social and Economic Need Index data. And the purpose of this index is not to compare counties to each other. I know the slide kind of looks like we're making that comparison. We're not. The reason we're displaying the data like this is so you can see how targeted needs may differ. So for example, in County A, the green data point is for that respective county, and the blue data points are for the rest of the counties in the state. So we can get a sense of for relative need. And as you can see in County A, homelessness is a major area of need. With some like the rate of older adults living with HIV or English proficiency isn't as much of a need. But for County B, that story is much different, right? Language services is a major need. Alzheimer's also at the top. So the needs are going to be different. And then when we look at need across counties like this, I think it may be helpful when targeting interventions in communities and really understanding what respective needs are. So that was my final slide. I'll hand it over to the next speaker. I just want to thank everyone for their time this morning. Look forward to collaborating in the future. Thank you.
Hi, Ross. Thank you. And for those of you that do not know me, my name is Denise Leiker. I am Deputy Director of the Division of Home and Community Living. And the next section we're going to talk about core programs. These programs and services are the foundation to the AAA's work throughout California. The Older Americans Act passed in 1965 and supports older adults so they can live at home and in the community with dignity and independence. This act has been the foundation for more than 5 decades, upon which the federal, state, and local organizational infrastructure has been developed, planned, and delivered as community-based services for older adults. The services are the foundation of the core program and services AAA's deliver today. On the screen, you see the OAA 4 program areas in order of highest to lowest utilization. In the following slides, we're going to talk a little bit more at a high level about each of these programs and how they serve community needs. So for the next slide, our first area is nutrition, a fundamental need and a highly utilized service across the state of California. Nutrition activities include, but are not limited to, meals provided in a congregate group setting or a place of residence, as well as education and guidance to those who are at risk due to their health and dietary intake, chronic illness, or medication use. Now, these again are very high building blocks in terms of the services provided under nutrition, but are at the local level, the AAAs have the ability to customize these services and pull in other services in order to meet the needs of their community. Next, we have our supportive services. Supportive services, again, the primary examples that the AAAs can build upon to customize for community needs is information and assistance with access to service coordination tailored to help link the individual to services that will assist with meeting identified needs. Next is disaster planning and emergency preparedness. Materials, kits, education, advice are all at the fingertips of the AAAs in order to be able to help those be prepared for any kind of event that could happen across the state. And living in California, we've seen a tremendous uptick in many of these types of events in terms of from rains, fires, and associated. So therefore, these are very critical to our community being able to provide this information. Next is legal assistance. This is an area where services can be provided as needed to our older adults, including advice, counseling, and even representation to handle legal matters in order for them to remain safely in the community. And then last core area is assistance with meeting mental health needs through screening, assessment, and linkage to services that will improve or maintain mental health. All of these areas, again, have very unique ways that you'll find that they're delivered in your local communities. Next is our Family Caregiver Support Program. The Family Caregiver Support Program focuses on the caregiver through supportive and supplemental services that are designed to help in the delivery of care in their role as a caregiver of an older adult, 60 years and older, someone living with Alzheimer's or other neurological disorders, or grandparents or older adult relatives caring for a child or someone with a disability. Often these services are seen as preventing burnout, promoting the caregiver's self-care, and aiding in day-to-day management of this role. So on the slide, you see a little more detail in each of these areas in terms of the supportive services through groups of caregivers, services that include the ability to get caregiver assistance at home with homework, housework, yard work, and other routine maintenance, and supplemental services to make minor or major physical changes to the home again, with the goal of continuing the care in the community, in the home of the older adult's choice. And then lastly is respite. Very key to helping our caregivers be able to get their own self-care where needed, getting assistance with breaks in caregiving to go to medical appointments, as well as to attend to other needs so that they can maintain their caregiving role. And then the last core area of the Older Americans Act is health promotion, which focuses on improving health and well-being to reduce disease, injury, and improve healthier outcomes for older adults 60 and over. This is done through evidence-based programs, and on the screen you see several of the topics: managing chronic conditions, alcohol and substance abuse, smoking cessation, weight loss, stress management, falls prevention of physical activity, and improving nutrition. These programs are provided in group settings, also one-on-one, and are really there in order to help be more preemptive as well as stabilizing for our older adults to be able to manage better in the community. So with that, we are going to transition to the next area, which is participant eligibility. So on this slide, we have the eligibility criteria for nutrition, supportive services, and health promotion. So at the top of the slide, you see the basic eligibility for these three, which is 60 years and over, regardless of income. Individuals with a disability who are age 18 or older, regardless of income level. And older adults with greatest economic or social need with particular attention to low income and minority individuals. For our nutrition programs, we have an additional category of eligibility. And this includes spouse and domestic partners of someone who is participating in the elderly nutrition program and is over 60, as well as homebound individuals who are in that situation due to illness, disability, or social isolation. So these programs are designed to reach as far as they can into our older adult communities. And the nutrition program is also to support those that are living with individuals that are. Next is our family caregiver support program. This program has two major areas, if you will, of eligibility. First is adult family members 18 and over who are in the role of informal or unpaid caregiver of someone who is 60 and over, regardless of income level, or caregiving for an individual with Alzheimer's or related neurological or organic brain dysfunction, regardless of age and income level. The other category are grandparents, are older relatives who are related by blood, marriage, or adoption and are 55 years and over, and are living with and providing care to a child who they are the identified primary caregiver, or providing care to an individual with a disability. So again, wrapping around many different populations that need support in our communities. And so that wraps up the Older Americans Act programs, which are which we said are a foundation that all of our AAA services are built upon. But there's two other core programs that I want to mention today before I wrap up as being a part of our AAA network across the state as well. And that is the Long-Term Care Ombudsman and the Health Insurance Counseling and Advocacy Program. The Long-Term Care Ombudsman Program assists residents of long-term care facilities with issues related to day-to-day care, health, safety, and personal preference. Health Insurance Counseling and Advocacy Program, also known as HICAP, provides free, confidential one-on-one counseling, education, and assistance on Medicare, long-term care insurance, and other health insurance-related issues to help people make the choices that are best for them in terms of meeting their health care needs. And with that, that wraps up a very high level view of our core programs and services. There is more information that you can find on the California Department of Aging's website on how to locate these services and a AAA near you, and gather more information on how our local partners have customized these services based on the communities that they serve. And with that, I am going to turn over to the next presenter, Nicole Shimasaka, our Deputy Director of the Division of Administrative Services.
Thank you so much, Denise, and good morning, everyone. I am going to walk through the intrastate funding formula, which I do want to caveat. This is a very complex formula with multiple steps. So I'm going to go through this, and if there are questions at the end, please, by all means, reach out to the email address that is provided to you, and I'm happy to share further with you. But we can begin. So first, the intrastate funding formula is how we allocate our Older Americans Act dollars, which are the Title III funding that CDA receives. Because we are the state unit on aging for the state of California, it is our responsibility to develop and maintain a formula to distribute these funds. The laws that govern the formula, also known as the IF, are the Older Americans Act and the Older Californians Act. And both acts dictate how we allocate the federal funds, state funds, administration funds, and then any funding that is used for non-match purposes, so excess general fund. Prior to starting the formula, we must first estimate what we believe will be the grant amount award for that year. There are a few reasons we have to use an estimate and not actuals at the onset of the formula, primarily because we operate on a state fiscal year and we receive the award on a federal fiscal year. So we don't actually have the notice of award from the federal government telling us our full amount at that time. So we use an estimate based upon what we received in the prior year in order to complete our initial calculations. Next slide, please. So here is an example. I just used 40 million because it's kind of an easy amount to use an example for, but we do receive more than $40 million annually. It's just an example. So what we do is we have an estimated grant amount. So we'll start with 40,000 as our estimate, or excuse me, 40 million is our estimate. 5% is used for CDA administration. So that comes off the top. We take the long-term care ombudsman program funding off the top. In this example, it's $1 million, but that again is not accurate. It's just for example purposes. And that amount for the ombudsman program is consistent year to year. So it's a fixed amount. And then what's remaining is going to be what is for the AAA partners for their administration and their program activities. Of the remaining amount, which you can see in this example is 37 million, 10% is set to the side for administrative purposes. And that would be the AAA administration that is set to the side. So you can see in this specific example, there's just over 33 million remaining for AAA programmatic activities. And we'll get into the next slide, which shows how those funds are allocated. We use a variety of factors and weights to allocate the AAA programmatic funding. The areas we look at are greatest economic need, greatest social need, other individuals, and Medi-Cal underserved. You can see under the column titled factors, specifically what we're looking for. We're looking for individuals age 60 and over who are low income, so below the federal poverty line, minority, geographically isolated or living in rural areas, non-minority, so individuals who identify as white or Caucasian, and then individuals who are Medi-Cal eligible. Within the source column there, you can see where we receive that data, and we receive that on an annual basis. So taking the funding that was determined to be for AAA programmatic activities, we then allocate the funding using the factors and weights from the prior slide. Once we've allocated that funding, we review the funding that's within Title 3B, C1, and C2, and we complete our first hold harmless test, which is the year 2000 test. And that's to ensure that the funding that the PSA is receiving is at least as much as what they received in the year 2000. If a PSA falls below the amount they received in the year 2000, we bring them up to whole using the federal and state general funds. And then at that point, the formula stops for them. They are brought whole to the year 2000 amount, and they are not included in the subsequent steps thereafter. All other AAAs or PSAs that were already above the year 2000 amount will continue forward with the formula. Next slide, please. At this point, we have determined the amount of funding that is for the local program activities. We've allocated it based upon the factors and weights, and we've conducted the first hold harmless test based on the year 2000. We now are going to do the state allocation process, which is how we provide the match required from CDA as a state unit on aging. CDA is responsible for a 5% state match requirement, and we use the general fund in order to meet that match. All general fund is provided to us in, or the majority of general fund, excuse me, is provided to us in nutrition, but that can be used for to meet our match requirements for the entirety of the formula, including 3B, which is supportive services. How we allocate the match is outlined within Welfare and Institutions Code 9112. Next slide, please. So at this point, we've figured out the total amount that's going to the AAA, how much is going to go to admin, how much is programmatic, and we've conducted our initial allocation, including the first hold harmless and our match. At this point, we pivot and we review the AAA administration amounts. Remember that we took 10% from at the onset, and we allocated that to the side for the AAA administration. At this point, we now take that 10% amount, which in this example is 3.7 million, and we provide 50,000 to every single PSA in the state. That is the base funding level that every single PSA receives. What is remaining thereafter is then distributed based upon the population of individuals within a PSA that are over the age of 60. So $50,000 base, the rest distributed based upon the number of individuals age 60 plus. And then thanks to a legislative budget request that was approved a few years ago, every AAA now receives an additional complement of $100,000 general fund added to the administration amounts. So the 100,000 is outside of the formula, but it is important to include within the contract because it is a part of the overall AAA administration that is available for our partners. Some people like to think of it as a $150,000 base, which is fine, but it is important to note that that 100,000 sits outside the formula and is added on top and is not altered in any way by the factors or weights. So at this point, we've done our first step and our first hold harmless of the AAA program funding, and we've allocated the AAA administration funding. At this point, any general fund that is still available for distribution is considered overmatch. Overmatch is not used to meet match. We've already done that. We've met match in the prior steps. So now this is just general fund that's above and beyond. Overmatch is used to meet our second hold harmless, which is called the maintenance of effort. The maintenance of effort is calculated by comparing the prior year's allocation amounts to the current year's allocation amounts. We do that in the 3B, 3C1, 3C2, and 3D categories. So this hold harmless is to ensure that the AAA receives at least as much as they received the year prior. If there is sufficient general fund to bring all AAAs up to whole to provide to them what they received in the year prior, that is how the funds are distributed. If we don't have enough funding to do that with the general fund, we bring them up equitably to as close to their maintenance of level effort as possible. This is the second of 3 hold harmlesses. The final hold harmless, which is used with surplus overmatch, is much more convoluted, and this step does get confusing if you're not familiar with the formula. In this step, any funding that is left above and beyond meeting the maintenance of effort from the year prior is coined surplus overmatch. And we use this to make sure every AAA has at least as much funding as they received in 1984 and 85. We take the surplus overmatch and we provide that to the AAA to bring them to that 84 and 85 level. If there's not enough funding to do so, we step back a step to the overmatch step, the previous slide. We reduce the amount that the AAAs receive for the maintenance of effort, and we use that to bring the AAAs to their 84, 85 level. So this, depending upon how much general fund we have and how the factors and weights and formula plays out, we might step back and reduce the maintenance of effort level to bring them to 84, 85, and then make sure that overmatch is distributed equally in that previous step again. Next slide, please. At this point, only for the AAAs that have not had to rely on the hold harmless levels to make themselves whole. So the PSAs that have factors and weights that have provided them more funding than the hold harmlesses are now going to receive funding through what is called the Washington formula. And this is the final step of the formulas. There are 7 factors here. This is literally adopted from the the state of Washington, and which is why it's called the Washington formula. And it reviews, population, SSI population, minority, square miles, individuals who live alone, and those who are non-English speaking. So next slide, please. We use these factors in order to allocate any funding that is left beyond all the prior steps. So if there's still a general fund balance, the AAAs that did not rely on those hold harmless will receive this additional complement of funding based upon those Washington formulas or Washington factors and the formula. At this point, the formula is complete. We have run through the entire process, and our federal and our state general funds are officially allocated at this time. We then use these allocations to build in the contract for the current year, and that is what is released to the network. That is my presentation. And again, if you have any questions, please reach out to the inbox at the end of this slide show. I am now going to turn it over to our Chief Deputy Director, Mark Beckley, for our next steps.
Great. Thank you so much, Nicole. I'll be presenting on the key traits and principles that guide our work to constructing a future-ready California, as well as the next steps in our process to move this work forward. So in terms of the key traits and principles, and this comes from the work that we did with the CA 2030 work group, very collaborative process, and a process that I think really developed some really strong principles to guide our work going forward. The first is aging and disability forward. So we're committed to continually improving our programs and services that support older adults and persons with disabilities, that all of our programs are inclusive and equitable, meaning that we serve all Californians and tailor our programs to serve the needs of diverse communities throughout the state, that our services are well-known and accessible. I think we often say that our AAA and independent living centers are the state's best kept secrets. Lots of great services that all of you offer. Unfortunately, not more Californians know about them. So a key goal is to further publicize and promote our services and make sure that they're accessible to all Californians. Consistency. So what we're seeking to do is to ensure that both the types of services that are offered and the quality of services are consistent regardless of where you live in the state. That our services are locally responsive. So while we're always striving to ensure that the services are consistent across the state, we also want to ensure that they're tailored to meet the needs of local communities. That we always take a strategic and action-oriented approach to our work, meaning that we're looking to structure our services in a way that are scalable, with the focus always on the person, and that we promptly take actions after our plans are developed. That our work is performance-based and outcome-driven. So we're always looking to improve our programs and construct good performance metrics so that we can actually measure the work that we're doing, really measure and monitor the actual outcomes that our programs and services have on our customers, and that it's also a way to hold ourselves accountable. And then finally, integrated, seeking to ensure that all of our programs and services are integrated into existing social and health services structures so that we can really take a holistic, person-centered approach to the work that we do. Okay, next slide. So this is some of the next steps that we have going forward in our work. And actually, in terms of the first next step, this is work that's already underway. So as soon as the CA 2030 report was finalized in January, we got to work internally on the key recommendations. So this includes potential changes to what Nicole just presented, the intrastate funding formula, PSA boundaries or planning service area boundaries, and core programs, which is the topic that Denise had just addressed. So as you can see, our foundational work is currently underway, and we're working across our divisions, bringing in CDA executives and other subject matter experts to understand what's possible in terms of changes, what can be done internally with existing authorities, and what we'll need to do through convenings, policy or program memos, rulemaking process, statutory change, and more. So lots of good work underway. And I'll note that this year is a strategic planning year for CDA. So all of the work that we're doing on these change initiatives are also work that we'll be incorporating into our strategic planning thinking and processes as well. In terms of moving this work forward, we do have a very valuable vehicle underway, and thanks to Senator Roth, we have a Senate bill called Senate Bill 1249. This bill is currently moving through the legislature, and we continue to provide technical assistance to the California Commission on Aging and Senator Roth's office, who's the bill sponsor, to make sure that the bill achieves the intended goals while we continue to work on moving the goals of the master plan for aging and the recommendations of the final CA 2030 report. What you'll see contained in Senate Bill 1249 is references, like I say, to the establishment of core programs, to the possibility of reconfiguring planning service areas, and finally to outreach and publicity of our programs. And then what we will be doing after conducting this initial phase of research analysis is we will be then engaging all of you, our stakeholders, in this process, specifically our AAA partners, to bring scenarios and possibilities forward. So I do want everybody to know that the work that we're doing internally, we will be engaging on you. Right now, we're just creating sort of a foundation to work from, and then we'll start getting into collaborative discussions. And like I say, we're targeting late summer, early fall for that work. And then finally, as you all know, the Administration for Community Living released its final rule. The final rule also makes certain changes to our programs that we will need to implement by next year. And again, this is something that we'll be collaborating with our local AAA partners as well. Okay, so that concludes our presentation for today. I'm going to hand it back over to Connie to close us. Thank you.
All right, thank you, Mark, and thank you to everybody that presented today for all that very insightful information. Thank you everyone for attending today's webinar. Just a couple reminders that today's recording will be available on CDA's YouTube channel. The presentation will also be made available on CDA's website. I'm dropping in the links into the chat so you can grab it. And also, if you have any questions on any of the presentations presented today, feel free to email info@aging.ca.gov and we'll route it accordingly for a response. Other than that, I hope everybody has a happy Wednesday and thank you for joining our webinar today. Have a great day.